Hello, my name is James Inciardi, and I work for the VA hospital in Aurora, Colorado. The therapists here have been giving inhaled nitric oxide for quite some time, but just recently we changed to inhaled epiprostenol, also known as Veletri. This presentation attempts to discuss the process that the department manager, Dave, took to introduce this drug into the department and allowing the therapist to give this drug to the critically ill patients. Okay, here are my objectives. The objectives of this presentation are to describe the steps taken to train for a new skill or technology in department, describe at least two pitfalls that can happen in such an endeavor, and state how sources of power can be used to obtain needed resources for a department. A couple of abbreviations you might see in this presentation. INO means inhaled nitric oxide, and IEPO means inhaled epiprostenol, or Veletri. Okay. Excuse me. Okay, before I go further, I wanted to review Veletri a little bit. Veletri is a naturally occurring chemical known as a prostacyclin. It can be given intravenously, but for our purposes, it is given as a nebulized solution that's inhaled by the patient. It's often seen as comparable to inhaled nitric oxide. Nitric oxide has a few advantages over Veletri, but mostly when hospitals try to move to Veletri instead of nitric oxide, it's because of cost. Nitric oxide, it can be up to 17 times more expensive than Veletri. My department manager told me that Veletri cost $400 a day to run, while inhaled nitric oxide was over $2,100 a day to run. And since there's no proven clinical benefits of inhaled nitric oxide over Veletri, a lot of hospitals decide to go with Veletri instead of nitric oxide. So that's the main reason why they choose Veletri, is because of cost. Okay. And now I'm going to talk about Aerogen. Aerogen is a device that's commonly seen in hospitals, but in case you're unfamiliar, I'll just go over it briefly, over what it does. An Aerogen is a vibrating mesh nebulizer. It makes nebulizing medications easier, and it's more effective than conventional nebulizers. It's pretty simple, really. All you do is you take this part right here, and you plug it into the ventilator circuit. And so this is the inhaled gas coming in through this way. Then you put, this is the chamber where the nebulized solution goes, and then this wire here leads to a little button. You push the button, and it nebulizes whatever is in here. The mist goes into the circuit, and it goes into the airway. Okay. And with Veletri, it has to be given continuously. If the flow of Veletri is interrupted, then you can have a rebound effect, which is really not good. So what happens is, you think of it like an IV pump with the tube going into this chamber right here. Okay, and then so that way it's a continuous nebulization, and that's what we want to see. Okay. So the next slide here. Okay, so now to start at the beginning here, it's interesting to note that there was a doctor who moonlit at the VA who tried to get Veletri into the hospital. At that time, we had been giving inhaled nitric oxide for several years, but it was only used rarely. So her efforts proved to be fruitless. However, eventually, Dave was asked to get Veletri into the department soon after the COVID outbreak in March 2020, when it became clear that COVID would be a major public health challenge. Dave realized that he had to get his therapist trained on the use of Veletri. So to do that, he first introduced Aerogen to the department. At the same time, he contacted Aerogen and asked them to send a clinical specialist to do an in-service about using Veletri with Aerogen. This way, he wouldn't be throwing too much information at the therapist right away. Erigen agreed to send a clinical specialist named Dr. R to the hospital for training. A sticking point could have happened when the different departments had to figure out whose job it was to do what. Respiratory therapists would be responsible for giving the drug. But why respiratory therapists? Why not nursing? They were already familiar with the pumps, the nurses were. And what about pharmacy? Should they be responsible for mixing the drug? Because the drug is very sensitive to light and has to be treated gently. So maybe the therapist should do it. And maybe the therapist should be responsible for monitoring the drug reactions, not the physicians. They're at the bedside, after all. Well, as it turned out, the roles that each department played fell together rather seamlessly. Physicians would order the drug, the pharmacy would mix it and send it to the ICU, and the therapist would administer the drug at the dose requested by the physician. Because the pumps were still new to the therapist, nursing would be there to ensure that the pumps were being programmed correctly and to answer any questions that the therapist had about the pumps. But if the different departments did not agree, then the result of the conflict would be the result of a power struggle. So here are the sources of power as listed on Bowman and Deal on page 192 and 193. If you want to look at them, I suggest going back to the book. Now, I apologize for running through them really quickly, but I'm trying to keep this presentation brief. So if you want to look at these more, I encourage you to go back into the book and take a look for yourself. Now, going back for just a second to the doctor who tried to get Veletri in the hospital, you know, the one who was moonlighting from another hospital. She tried to get Veletri in there, but she didn't have the power. And she was right, because if she had been successful, we would have Veletri ready to go on day one of the pandemic. But unfortunately, she didn't have the power to do it. And it just goes to show that you can be correct on trying to get something done, but if you don't have the power to do it, it's just not going to get anywhere. Okay, so the sources of power, according to Bowman and Deal, are positional power, control of rewards, coercive power, information expertise, reputation, alliances and networks, access to and control of agendas, framing, and personal power. It would be up to Dave to draw on one of these sources or more, one or more of these sources of power to achieve the result that worked best for his department. So, to continue with the case study, Erigen sent a representative named Dr. R to do an in-service with our department. The in-service didn't take very long, it was only about an hour, and all of the RTs were able to attend one of the two study sessions. Actually, there was one RT who was out of town and not able to attend the in-service, and that RT called Dave, and they worked out another plan so that RT could get the training that they needed. Now, because the VA is a federal entity, we can get around some rules that other hospitals have to follow. For example, I'm not licensed to work in the state of Colorado. I have a license from the Board of Medical Practice in Minnesota. Another manager has a license from the state of Utah. It doesn't matter. As long as you have a license from somewhere in the United States, you can work in any state in the VA system. However, I'm not so sure how much that comes to play when trying to start Veletri. For example, when I worked at another hospital in Minnesota, this hospital wanted to license their respiratory therapists to work with ECMO machines, and the state wouldn't allow that licensure to take place. That hospital had to make it clear to the Minnesota Board of Medical Practice that only after they were assured that the therapists would undergo extensive training program and that they would continue to work as respiratory therapists at least a few days a month, only then did the Minnesota Board of Medical Practice approve this action. Excuse me. Now I'm going to give Dave a grade for introducing this change into the department, and I'm going to give him a B+. Dave did a good job in introducing the Veletri into the department. It got done, and it got done pretty quickly considering how things like this usually take a pretty long time, especially at the VA. He used the structural frame to determine who was responsible for what. He used the political frame to communicate with other departments and get the change that he wanted to happen. And he used the HR frame when he initiated needed training for his therapists. But could he have done better? Well, yeah, in retrospect. Hindsight is 20/20, as they say. He didn't use the symbolic frame, and he also didn't do a very good job at communicating this change to the department. What he did was he sent an email to everyone explaining the change that was going to happen. But the thing is, though, that therapists get about 100 emails a week. I'm not exaggerating. So it would have been best to talk to his therapist face to face. Tell them what changes are going to happen and why they're happening. And while they're having that communication, he could have established a vision or a sense of urgency as dictated by Cotter. By failing to do this, he missed an opportunity to set a sense of direction for the department, or a mission for the department, I should say. We're going to be a department with a wider scope of practice, he might say. We're going to have a lot more tools under our belt to help our patients. And that would have been a great message to convey to the department. That would have made the therapists excited for the future and whet our appetites from other changes to come. Nevertheless, the bottom line is he got the job done, and that's the most important part. Now here's a picture of the inside of our hospital, and I'm sorry to brag, but our hospital is easily the best looking hospital I've ever seen. It's only a couple years old, and you feel like you're walking around a piece of art. The hospital cost over $1 billion to create, so it should look good. Anyway, today we have a couple of Veletri pumps that we're borrowing from UC Colorado. The pumps we need are on back order. Dave told me that ordering certain supplies at the VA is a bit of a hassle and takes a long time, and that's something that's kind of out of his control. But we have given Veletri a handful of times now. We still have the inhaled nitric machines, but I don't think that they've been used in a while now. One question that you probably have is, how often is Veletri given here in the hospital now that we've got it? Well, unfortunately, I don't really have those numbers. In my personal estimation, in a given week, I think we'll start a Veletri treatment maybe between 1 and 3 times a week. Not all therapists yet have given Veletri. Personally, I haven't given it at this hospital, but I've given it at another hospital. All right, and these are my references. Thank you for listening to my presentation. I hope you learned a lot from it, and if you'd like to contact me, feel free to email or call me. And thank you again for your attention.